Hello and welcome. Thank you for joining me. Today we'll be covering brief interventions. Specifically, we'll go through a quick guide that will give you a solid understanding of what they are, why they're so important, and how you can apply them in your own practice. So, let's get started. So, what exactly are brief interventions? At their core, they involve three key things: screening a patient's alcohol or drug use, assessing the level of risk, and then providing tailored advice to help them make positive behavioral changes. The primary aim here is to give people clear, useful information about the risks associated with their substance use and to encourage them to reduce their consumption. What's really key is that these interventions are designed for people who aren't necessarily seeking help for substance use. They are often identified through routine screenings in a general healthcare setting. This makes brief interventions an incredible opportunity for early engagement. It's important to understand who they are most effective for, and we'll spend a little time covering this soon. Suffice to say, the evidence shows they work best for individuals who are classified as at risk of developing dependence, not for those who are already dependent or experiencing very severe harms. Those individuals require more intensive, specialized treatment. This brings us to the why. Why should we be integrating brief interventions into our daily practice? Well, the fundamental reason is that early intervention can prevent the development of more serious substance-related problems and dependence down the line. It's a proactive approach to health promotion and disease prevention, especially valuable in a primary care setting. Think about the numbers. Over 80% of Australians visit a primary healthcare clinician every year. This provides us with countless opportunities to have these important conversations. Often we can link the discussion to a common health issue the patient is already presenting with, which can be a natural way to introduce the topic of substance use. And what about the patient's perspective? Research shows that patients see their primary care providers as credible and trustworthy sources of advice on health risks, and that includes substance use. They are generally more comfortable discussing sensitive topics like this with a clinician or organization they already know and have a relationship with. Now, let's turn our attention to the evidence behind brief interventions. While the efficacy can vary across different substances and behavioral addictions, there is a strong and robust evidence base in several key areas. For alcohol use disorders, there's incredibly strong and consistent evidence supporting brief interventions, particularly for individuals who are at risk of developing dependence. For example, a major 2018 Cochrane systematic review, which looked at 69 studies, found that these interventions significantly reduced alcohol consumption. We're talking an average of 20 grams per week at 1-year follow-up. More recently, a 2021 meta-analysis of 116 trials also demonstrated small but significant beneficial effects. What's even more encouraging is that the WHO Brief Intervention Study Group showed that even very short interventions, as brief as 5 minutes, can be just as effective as longer counseling sessions in reducing alcohol consumption. When we look at the factors influencing this effectiveness, we see that these interventions are most impactful when delivered in community and general medical settings, ideally lasting between 5 and 15 minutes. And specifically targeting individuals who are at risk rather than those already experiencing severe dependence. Similarly, for tobacco use, brief interventions for cessation have a very strong foundation of evidence. Numerous clinical trials and systematic reviews consistently support their efficacy. Even minimal advice, sometimes just 3 to 5 minutes from a healthcare professional, can lead to a significant increase in quit rates. And when we combine this advice with more intensive interventions, such as providing practical assistance, self-help materials, recommending pharmacotherapy, or making referrals, we see even greater effectiveness. Major organizations like the US Public Health Service and the National Institute for Health and Care Excellence widely recommend and endorse brief interventions for smoking cessation across all healthcare settings. However, the picture is a bit different for other substances and behavioral addictions. The evidence for brief interventions targeting illicit drugs, excluding cannabis, is substantially weaker, and it doesn't currently support widespread implementation in primary care settings. For cannabis use, systematic reviews have shown mixed results. Some studies indicate modest reductions in use days, while others haven't found significant effects on screening scores. When it comes to behavioral addictions like gambling or internet gaming, the evidence is promising, but still quite limited. Some studies suggest that brief advice can reduce gambling days, but we still need more high-quality randomized trials in these areas. Finally, let's touch on some key factors that influence the efficacy of brief interventions. As already mentioned, they are most effective for individuals with mild to moderate substance use problems. A patient's baseline motivation to change and the absence of depression also predict better outcomes from brief interventions. And consistently, we find that general practitioners often achieve better results when delivering drug-targeted interventions. Now, let's look at the how. There are a couple of structures we can use to guide a brief intervention. One very common and effective framework is the 5 A's. The Australian College of GPs endorses this approach and has a great guide and related resources on their website. The framework is commonly used when talking to people about tobacco use and cessation, but isn't limited to that setting. It starts with ask. At every visit, you should ask about and document the person's tobacco or substance use status. For tobacco, a tool like the Fagerstrom test can be useful here. Next is advise. This needs to be done in a clear, strong, and personalized way. Don't just say, you should quit. Explain why it's important for them and their health. Consider using a motivational interviewing approach, which involves an empathetic, non-judgmental style to help the patient explore their own reasons for change. We'll explore this approach more in a later slide. It's also crucial to support this advice with self-help materials they can take away. Then, assess. This is a simple question. Is the person at a point that they want to make a change at this time? Understanding where a patient is in their readiness to change, perhaps by considering the widely used stages of change model, can be very helpful here. We'll delve into that model in a later slide. If the answer is yes, you move to assist. This is where you actively help them. This could involve providing counseling, recommending pharmacotherapy, and directing them to resources for quitting or changing their use. If the answer is no, it's vital to acknowledge their decision without judgment and focus on building motivation, keeping the door open for future discussions and offering resources. You can still provide assistance by offering factual information in a non-judgmental way, reinforcing their personal responsibility and providing self-help materials or links to other services they can review at their own pace, leaving the door open for future readiness. Finally, arrange. You need to schedule a follow-up contact. This could be in person or by phone, and it's best to do it within the first week after their planned quit or change date to provide support and see how they're progressing. Another excellent model to consider is the FRAMES approach. This acronym handily summarizes the key components of an effective brief intervention in a slightly different way. F is for feedback. Give the patient feedback that is personally relevant and based on the screening assessment you've just done. For example, you might say, your screening score suggests your drinking patterns are putting you at increased risk for liver problems, or your current tobacco use is significantly impacting your lung function. This feedback should be objective and non-judgmental, based on test results or observed health issues. R is for responsibility. It's crucial to emphasize that the responsibility for making choices lies with the patient. You can communicate this by saying, it's ultimately your decision what you choose to do about this, or I can offer you options and support, but the choice to change is yours. This respects their autonomy and empowers them. A is for advice. Provide clear, direct advice about the harms of their continued use and the benefits of changing. This isn't about lecturing, but stating the facts. For instance, my advice is to reduce your alcohol consumption to within the national guidelines to protect your health. Or, quitting smoking is the single best thing you can do for your heart and lungs. M is for menu. This is about offering a menu of options, not dictating one path. Give them a range of different strategies they could use to reduce or stop their use. This is particularly important because different options will resonate with patients in different stages of change. Examples might include, some people find it helpful to set limits for themselves, others prefer to try complete abstinence, or perhaps exploring a nicotine replacement therapy could be a good first step. Providing these choices is incredibly important as it reinforces their sense of personal control and responsibility. E is for empathy. Always use an empathic and non-judgmental style. This is a core component of motivational interviewing. Listen reflectively to understand their perspective, challenges, and feelings. You might say, "It sounds like you're feeling really stressed and that alcohol helps you cope." Or, "I understand that quitting smoking can be incredibly difficult and many people struggle with it." S is for self-efficacy. Work to instill confidence in the patient's own ability to make a change. Your belief in their ability to succeed can be a powerful motivator. Acknowledge past successes, no matter how small. You've successfully cut down before, so you know you have the ability to make changes. Or, "Many of my patients have found success with these strategies, and I believe you can too." This builds their confidence and encourages them to take action. Remember that many people may want to make change, but feel discouraged because they don't know where to start. So far, we've discussed the importance of brief interventions and how to conduct them using frameworks like the 5 A's and frames. Now, let's delve into some additional useful ingredients I've already briefly mentioned that will help you enhance your practice. We'll cover screening tools, guidelines, the stages of change model, and motivational interviewing. To do an initial assessment of substance use and target your interventions to the right people, you need the right tools. Here are some of the most common and validated screening tools in use. For alcohol, there are tools like Audit and the CAGE questionnaire. The CAGE questionnaire is a brief, 4-question screening tool designed to identify potential alcohol problems. It asks about cutting down, feeling you should cut down on your drinking; annoyance, people annoying you by criticizing your drinking; guilt, feeling guilty about your drinking; and eye-opener, needing a drink first thing in the morning to steady your nerves or get rid of a hangover. For tobacco, the Fagerstrom test for nicotine dependence is the standard. This 6-question test assesses the intensity of physical addiction to nicotine, considering factors like the number of cigarettes smoked per day, time to first cigarette after waking, and difficulty refraining from smoking in forbidden places. It helps gauge the level of nicotine dependence. And for general or other substances, you have tools like the Drug Abuse Screening Test or the BDEPQ for benzodiazepine dependence. The aim of these screening tools is to identify individuals for whom a brief intervention might be effective, particularly those classified as at risk of developing dependence. The results provide a valuable foundation for personalizing your advice and tailoring the conversation to their specific needs. Based on the outcome of the screening, a great technique for giving feedback is the elicit, provide, elicit method. You first elicit what the patient already knows. Then you provide your information and advice, and then you elicit their reaction or what they make of that information. It turns the conversation from a lecture into a collaboration. When giving advice, especially about alcohol, it's helpful to be familiar with the official national guidelines. Here are the Australian guidelines aimed at reducing health risks from drinking. For healthy adults, the recommendation is no more than 10 standard drinks a week, and no more than 4 standard drinks on any single day. The simplest message is always the best. The less you drink, the lower your risk of harm. For children and young people under 18 and for women who are pregnant or breastfeeding, the advice is simple and clear. They should not drink any alcohol. This is to prevent harm to the developing brain, an unborn child, or a baby. While national guidelines for other substances like cannabis, opioids, or stimulants may not be as available, the underlying principle remains consistent: harm reduction. The goal is always to reduce the risks associated with substance use. This often involves discussions about avoiding high-risk situations or safer use practices if complete abstinence isn't feasible. It can also be helpful to discuss the effects of polydrug use and knowing the signs of overdose. For these substances, personalized advice should draw on clinical knowledge, the patient's individual risk factors, and available resources for safe practices or treatment. The focus shifts from strict numerical limits to mitigating dangers and promoting healthier alternatives where possible. Motivational interviewing, or MI, is a powerful standalone intervention, and it's particularly effective for people with less severe alcohol dependence. The core principles are also useful in delivering brief interventions and can be remembered with the acronym DARES. Develop discrepancy. This involves helping the patient see the gap between their current behaviors and their broader life goals and values. For example, you mentioned you value your family's well-being, but your drinking habits seem to be causing conflict at home. How do you see these two things fitting together? Augment ambivalence. It's normal to be ambivalent about change. MI explores both the pros and the cons of their substance use and of making a change. For instance, on one hand, you enjoy how smoking helps you relax. On the other hand, you're concerned about your cough and how it affects your breathing during your walks. What are some other things that you like or dislike about your current use or about changing? Roll with resistance. Resistance is a natural part of the process. Instead of arguing, you accept it and gently invite the person to consider new information. As an example, if the person says, "I'm not ready to quit smoking," you could say, "You're making it clear that you're not feeling ready to quit right now, and that's perfectly understandable. What would need to change for you to consider it?" Express empathy. This is fundamental. You must use an accepting and non-judgmental approach to truly understand their point of view. For instance, it sounds like you're feeling really overwhelmed by everything right now, and using cannabis helps you escape some of that stress. I can understand how that might feel like a necessary coping mechanism. Support self-efficacy. Just like in the FRAMES model, you focus on building the person's confidence in their own ability to make a change. Your belief in their ability to succeed can be a powerful motivator. For instance, you've made some positive changes in your diet recently, which shows you have the determination to set and achieve health goals. How might you apply that same strength to reducing your drinking? When we talk about change, it's important to recognize that it's a process, not an event. This model shows the stages of change. Understanding which stage a person is in can significantly help tailor your intervention, as different stages require different approaches. Many of the people you speak to will likely be at the pre-contemplation or contemplation stage. In pre-contemplation, someone has no real plans to make a change. At this stage, the intervention should focus on raising awareness of the potential risks and benefits of change without pressure or judgment. Someone else may be at the point of contemplation, where they are feeling ambivalent, seeing both the good and bad sides of their substance use. Here, the goal is to explore that ambivalence, helping them weigh the pros and cons of changing and strengthening their desire to move forward, often using motivational interviewing techniques. In the preparation stage, people have decided to change but haven't started yet, and may not know where to start. Your role here is to help them set clear goals, develop specific action plans, and identify practical resources and support for their upcoming change. Action is when they actively begin to change their behavior. During this stage, provide consistent support, teach coping skills for challenges, and affirm their progress to maintain momentum. Maintenance is the long-term effort of sustaining that change. In this stage, the focus is on reinforcing coping strategies, anticipating and planning for potential high-risk situations or triggers, and celebrating their continued success to prevent relapse. It's also important to acknowledge that a lapse, a brief return to use, or a relapse, a full return to previous patterns, can happen. Our role is to help the person see this not as a failure, but as part of the journey, and help them get back on track by re-engaging with the change process, learning from the experience, and reinforcing their self-efficacy. Theory is one thing, but seeing it in practice is another. Please pause the presentation now and watch the video at the link on screen. It provides demonstrations of brief interventions and examples of the techniques we've discussed today, showing how the conversation flows in a real-world setting. You can also find a clickable version of the link in the description section below. To make screening even easier, there are some great online tools available. The eAssist, or Alcohol, Smoking and Substance Involvement Screening Test, is a well-validated screening tool developed by the World Health Organization to identify, assess, and manage substance use. The eAssist portal is an online self-completion version of this tool adapted for the Australian context, making it highly relevant. Like in the last slide, I've included clickable versions of the links in the description section below. Patients can use this tool to assess their own substance use privately. There's a full version which provides a comprehensive assessment across various substances and also a light version designed for quicker screening. So, to wrap everything up, let's quickly reiterate the benefits of brief interventions. They are efficient, proving just as effective as longer, more intensive interventions for at-risk individuals. They are versatile, meaning they can be used in many different healthcare settings, not limited to primary care. They are effective, proven to work for those at risk of developing dependence. And, most importantly, they are empowering, helping patients feel in control and able to take charge of their own substance use. I'd encourage you to think about how you can integrate these powerful but simple interventions into your practice. And that brings us to the end of the presentation. I'll leave you with links to some additional key resources you may find useful in your practice. Thank you for your time and attention.